This section will help in identifying the anatomy for selecting the bone marrow aspiration site using the ilium surgical approach. The ilium may be approached posteriorly, anteriorly, or laterally, with the posterior approach being suggested to minimize aspiration site morbidity. The posterior approach requires palpation to locate the superior aspect of the posterior iliac crest. The anterior approach requires palpation to locate the anterior superior iliac crest. The lateral approach requires the patient be placed in a right or left lateral decubitus position and then palpation to locate the posterior iliac crest. First, prepare the surgical site and provide local anesthesia to the area unless general anesthesia is being utilized. Make a small oblique stab incision, a skin flap, just above the point of entry. This type of incision can easily be closed using a Steri-Strip or butterfly dressing following bone marrow aspiration. Remember, all marrow contact components must be rinsed with an appropriate concentration of heparin anticoagulant solution, including syringes and needle lumens and stylets, to prevent clotting. After identifying the anatomy and deciding on the needle trajectory, penetration of the ilium with the aspiration needle should be swift to avoid tissue factors coming in contact with the needle lumen and potentially resulting in activation of the clotting cascade. For an anterior or posterior approach, advance the needle by applying pressure simultaneously with back and forth rotation until a reduction in resistance is noticed, indicating entry into the soft marrow space. If there is difficulty in penetrating the ilium, simply tapping the aspiration needle handle with a mallet while holding the distal end of the needle at the point of insertion and at the appropriate angle should result in swift penetration of the ilium cortex. Penetration of the cortex will be noticed by a reduction of resistance as the needle enters the cancellous bone marrow space. For an anterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle medially in line with the pelvic wing as gauged by palpation of the inner and outer tables. The trajectory should be aimed slightly posteriorly at the iliac tubercle to enter the medullary canal just beneath it. For a posterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle approximately 40 degrees lateral from the sagittal plane and 35 to 40 degrees inferior from the transverse plane. A general rule is to aim at the tip of the greater trochanter. For a lateral approach, hold the needle horizontally and introduce it through the prepared incision site into the center of the posterior iliac prominence with the initial trajectory 15 degrees caudal. Following penetration of the ilium with the aspiration needle, advance the needle distally into the marrow space 4 to 8 centimeters for the anterior or posterior approach, depending upon the volume of the ilium. Remove the stylet and attach a heparin-rinsed 20 milliliter syringe. Pull a small aspiration of 5 milliliters of marrow. Please note that short, quick aspirations of small volumes results in a greater recovery of nucleated cells than a long pull of greater volume, which would result in dilution of the marrow with peripheral blood. If marrow does not aspirate easily, reposition the needle slightly. If marrow still does not aspirate easily, remove the syringe from the needle, remove the needle from the incision, and exchange the needle and stylet with a freshly heparin-rinsed needle and stylet. Reinsert the new needle into the incision site and penetrate the ilium approximately 1 to 2 centimeters from the original puncture site, as we described earlier. If the first 5 milliliters of marrow is easily aspirated, then the aspiration needle should be rotated 90 degrees, followed by retreating from the marrow space 2 centimeters, and another small aspiration of 5 milliliters of marrow is repeated, so that a total of 10 milliliters of marrow is now in the syringe. The aspiration needle should again be rotated 90 degrees, followed by retreating from the marrow space 2 centimeters, and another small aspiration of 5 milliliters of marrow is repeated, so that a total of 15 milliliters of marrow is now in the syringe. Care must be exercised to assure that the needle tip and side holes remain in the marrow space. If the needle tip and/or side holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet in order to prevent the likelihood of clotting of the harvested marrow. Remove the filled syringe containing 15 milliliters of marrow and immediately place it into the blood bag containing the heparin solution. Agitate or rock the bag so that the marrow is thoroughly anticoagulated. It's recommended to maintain the blood bag in motion as each volume of aspirate is added to the blood bag. Reinsert the stylet and advance the needle at a new trajectory along the same plane as the original insertion. The previous steps should be repeated, assuring that the needle tip and side holes remain in the marrow space. If the needle tip and/or side holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet, followed by re-entry into the marrow space as described previously. Reinsertion of a freshly heparin-rinsed stylet addresses two important aspiration issues. First, the stylet will prevent the possibility of the needle from bending or kinking, and second, advancing the needle with a distal hole and stylet in place will prevent coring of the marrow and possible blockage of the distal and/or side holes of the aspiration needle. This last issue could also result in the activation of the clotting cascade and therefore can be prevented by following this recommendation. The previous steps should be repeated so that an additional 3 small aliquots of marrow, 15 milliliters, are collected for a total of 30 milliliters in the blood bag from a single puncture site. Again, the previous steps should be repeated with a freshly heparin-rinsed needle and stylet and a new penetration into the ileum made approximately 2 centimeters from the original puncture site, or the opposite ileum can be used, so that another 30 milliliters of marrow is collected in 5 milliliter aliquots for a total of 60 milliliters of marrow being collected and placed into the blood bag. Here are a couple of good general rules to follow that should ensure a high nucleated cell yield. General rule number 1, always use freshly heparin-rinsed collection needles and syringes. General rule number 2 for marrow aspiration is to draw 5 milliliters per syringe pull, a total of 15 milliliters per syringe, and 30 milliliters per puncture site. A good way to remember this is to think 5, 15, 30. 2 puncture sites should easily yield 60 milliliters of bone marrow aspirate. General rule number 3, maintain the blood bag containing marrow in motion. Additional volumes of marrow can be harvested as needed following these guidelines and recommendations. Once all the marrow has been harvested, the blood bag should be inspected for signs of any clotting or bone spicules. Signs of excessive clotting may result in a poor recovery of nucleated cells. If seen, additional clot-free marrow should be harvested by closely following these collection guidelines.